Hello, and welcome to the Body Fusion Therapy Podcast. I'm your host, Dr. Heather Demercy. Today's episode is part 2 of the series, Finding the Root Cause of Your Pain. We're going to be talking about subjective intake or the patient interview. Now, listeners, if you aren't healthcare practitioners, you still need to hear this episode because you have the answer. Your history of what has happened in your body is the answer that the healthcare practitioner needs to hear to be able to figure out how they can help you get better and more efficient. So this episode is for you as well. It's for healthcare practitioners and also for the patient. I had a great teacher, Dr. Mary Hickey, who said that you should have a very good idea what the problem is just based on the interview of the patient. And I just think that was crazy. I was like, no, you need to have all of the different tests and measures that we learn as well to figure it out. And she always said, no, those tests and measures are to help kind of correlate what you're hearing with what is going on with their bodies, what you can measure objectively. So it's really important that we have a good understanding of a patient's history. And this is one of the ways we get to the root cause. It's by understanding that subjective intake or the patient interview. So in today's episode, our objectives are going to be about knowing your history, how to get the most info during the subjective intake, and then this idea of still building rapport. Even when the first eval is done and the kind of first meeting, that first interview, you still need to be having rapport with your patients to be able to kind of help that continuation of care. So let's go to history first. Patients, you need to understand your whole history, and the whole picture really helps. When you know your history and all of your history, it really helps to kind of break down what could be going on with you. Now, I would much rather get more information and decide what's relevant than you hold back info from me. And I've noticed that as I've talked about this on my Instagram page, now my patients that have seen it come in and they list everything for me, absolutely everything that's ever happened in their lives. And I love it. Because rather than me going and trying to poke and prod within their history, they already know that I am going to ask for every single bit of information. And it's a lot easier when leading up to the appointment, they're already thinking about these points rather than when they're in the room with me, I'm asking all these questions and they're having to jog their memory. So you really want to know your whole history before you go into seeing a healthcare practitioner. The body is all connected. And you know what, patient, you don't need to know that it's all connected. The PT, the expert that you're going to, that healthcare practitioner, they're the ones that should know how things are interconnected and playing together. But I would much rather have way more information than you think is necessary, because usually it is necessary. There's just cases where I don't think things are related or it's kind of, an artifact off to the side, but that's my decision of what's there, not what yours is. So you should know the timeline too. If you have a lot of history to your injury, then you should just start making a Word document. I have some patients that come in with this long page of information of kind of this chronological events of what happened with their body. And they always say like, oh, I'm embarrassed that I'm coming to you with all this information. I'm ecstatic. I am so happy that I have written down in front of me something that I can see as to what happened first and then what happened. And so when I'm talking to the patient, I can refer to that timeline and make notes there. So I love it when I get that extra piece of paper where everything's there, because let's be honest, there aren't many intake forms that have enough room to cover really complicated cases and to understand everything that's happened with the body. So sometimes having that Word document that you can also give your healthcare practitioner is really helpful. I also find this is really helpful when it can be hard to relive that history over and over again. When you treat patients that have a lot of chronic pain, or if you're that patient that has a lot of chronic pain, it's really hard to keep going to these healthcare practitioners and thinking they're going to help you and just being disappointed that it wasn't the answer you were expecting. And so it's hard each time going in to see somebody, having hope that maybe this will be the answer. And you have to just keep reliving that whole process. So sometimes it's easier when this is a long, arduous case for you that's been very frustrating. If you just have this Word document to give them, rather than trying to fill out all that paperwork and get it to fit in a little bit of space that you're allowed, it's easier to just have it all written out. And then as things continue to happen, you just add to that Word document. So I really suggest that if it's something that's been going on for a long time and you get confused sometimes when you're in the doctor's as to what came first, what came later, just having it down on a piece of paper that you can just forward to the doctor beforehand or bring with you is extremely helpful. Next thing is know your specifics. This is much more helpful. So if you say that it hurts when it's running, well, okay, is it when you're landing on that leg? Is it when it's behind you? Does it start at the beginning of the run? Is it more at the end of the run? Is it after the run? Where exactly does it hurt while you're running? You want to know the specifics because it really helps kind of breaking down the mechanics of what's going on with the injury. Or if the injury was because of an accident or some sort of event, you want to know the specifics. So say someone's in a car accident. I always ask, where were you hit? Were you wearing a seatbelt? Which direction were you looking? As an example, like I had a patient who was T-boned and they just said like, I was in a car accident. I'm like, okay, well, did you cause the car accident? Were you the victim of it? Was it a rear end? Did they hit you on this and finally got it out of him that he was T-boned and he was in the driver's side wearing a seatbelt, but he was talking to his friend in the passenger side when it happened. So he never saw it coming and he was turned to the right when he got hit on his left-hand side. The issue he had was a lot of pain down the arm. And what I was able to figure out was that because his head was turned so far to the right and then he got T-boned that way, it was almost like he got a whiplash going from the side, which stretched the nerves in his neck going down into his arm. So it wasn't so much from the compression of getting his door jammed in from this car hitting him. It was more as his neck whiplashed when he was looking off to the side. So understanding the biomechanics of an accident is really important. I had another patient. He was a guy coming in with post-concussive syndrome. So he had had a concussion a couple years beforehand and was still having symptoms. He had been treated in his head and his upper neck, but didn't have much improvement. So I asked him, well, how'd you get the concussion? So it was a surfing accident. So I started to kind of pry in a little bit more. I said, so did you hit your head like on the board? Did you hit your head on the ground? Were you in a reef? What exactly was it? And it turned out that he started to go nose down into the wave. And so he shot backwards with his head and then the board hit him underneath his chin and lifted his head up as he went down further into the fall. So for him, then I started looking at his rib cage because it's actually his rib cage that got the biggest brunt because he also said that the first pain he had was in between his shoulder blades. It wasn't in his head. It wasn't in his neck. It was in between his shoulder blades. So I knew he almost had this hyperextension injury from going face first and then his head going back. It just caused an issue through his rib cage. So to help his headaches, because his headaches and the symptoms he was still dealing with in his neck was because his head couldn't sit properly on his rib cage because his rib cage was out of alignment. So I had to go treat the rib cage to get his head and neck in a good position, which dramatically decreased his headache and his neck symptoms. So it was understanding the biomechanics and the specifics of that injury that really helped me get him better because he had been to many other physical therapists and vestibular therapists and other doctors for his concussion before without much of a change. So you really want to know your specifics, patient. You want to know exactly what happened, where were you looking, what was going on, and if it hurts while you're doing an activity, okay, when does it hurt? Where does it hurt? Just get as specific as you possibly can because you're helping that therapist or your healthcare practitioner figure out what could be the cause here. Because just saying that my head hurts after I got a concussion or that, my knee hurts when I'm running doesn't tell me as much. I need to know a little bit more to be able to dive into there. So that kind of brings into my next area of subject we're going to talk today is how to get the most out of the subjective intake. So this is a little bit more for the healthcare practitioners. I once heard a speaker from a big name school at a conference, and I was horrified. He came up and the whole subject of his talk was how to do the best subjective intake. And I was like, oh yes, this is going to be a great talk. And he starts by saying, all the questions should be yes, no questions. I don't want to hear specifics. I don't want to hear this long-winded story. I just want to hear yes or no. And I was horrified to look around the room and see all these people nodding their head in agreement that this is what they should do. And I'm thinking in my head, no, please don't think that way. Yes and no is not going to give you much information. You want to have those open-ended questions. So let your patients talk. Don't try to cut them off. Now, obviously, you know when you need to pivot and get them back on task if they start kind of going down this other avenue that's not giving you the information that you need. You need to be able to redirect them to where you're going, but it needs to be more than yes or no questions. You want to get as much information as possible. If you want to get the specifics, then you need to ask them questions more than just, were you in a car accident? Great. Were you the front car? Yes. You need to ask more like, okay, how did it happen? Where did it happen? Things like that to get the patient talking, to get more information out of them, because you don't know their history. They're coming into you for help. And if you kind of cut them off in terms of your questioning, it's not going to allow you to get to the root cause of the problem. So your questions need to be as open-ended as possible. And if sometimes you'll get it that they don't have a lot to say, where they don't really understand the specifics, where they're not fully aware of what's going on with their body. If that's the case, then you need to start asking more general health questions. And sometimes that helps jogs their memories. So I'll ask things like, well, have you had any surgeries? Or if there's injuries in other parts of their body, like the surrounding area. So say someone's coming in for ankle pain, and I can say, okay, well, have you ever had any knee issues? Or have you had any hip issues? If someone's coming with shoulder pain, any neck issues? You're just kind of asking questions to see if they can start to connect the dots and be able to give you more information. Because there's times that people they don't understand that they need to learn their story. They're not understanding that what you're asking them is to give you as much information as possible, and that it's your job to decide what is important information and what is kind of artifact information that they don't need to follow around with. The questions I always ask my patients, regardless of what they're coming in for, is if they've ever had any concussions, either diagnosed or undiagnosed. So I always joke that if you're over 20 years old, you need to be asked if any undiagnosed concussions, because let's face it, when I was younger, I full on lost consciousness in a car accident. And I said, I think I might have a concussion. And they're like, no, you're fine. You just got your bell rung. I most likely had a concussion. So sometimes there's a lot of concussions that went undiagnosed. So you need to ask either diagnosed or undiagnosed. Any big falls onto your tailbone. Now, the reason why I ask the concussions and the tailbone question is because I want to know if they've had any effect to their nervous system, if their dura, that saran wrap around their entire nervous system, has been affected at all. Because the sphenoid bone, the bone the brain sits on, and the tailbone, or the coccyx, are the anchoring points for the nervous system. So I want to know if either of the two of those are affected. I always ask about digestion. Are they regular every day? And I joke that if someone's regular every day, if they have a bowel movement every day, they are quick to tell you. They want to sing it from the rooftops. They're so excited. They're so proud. And honestly, they should be, because a lot of people don't have regular bowel movements. So if there's any sort of pause, usually that means that they don't have regular bowel movements. But I want to know, how's the general health of their abdomen? How is food flowing through? Because that tells me a lot. Because there are visceral restrictions around those organs that can be affecting upper body and lower body. So you want to know what's the general health of their digestion. I want to know if they have any nocturnal urination. That doesn't mean that they wet the bed. That means, are they getting up in the middle of the night to go to the bathroom? Because they should be able to hold their bladder the entire night, unless they're in their third trimester of pregnancy. Then yes, you just don't have the room. But even older men that say that, oh, well, yeah, just old age, I need to get up and pee in the middle of the night. No, you shouldn't have to pee in the middle of the night. Your prostate should have mobility. You should be able to hold it all night long. So I'll ask about nocturnal urination. I ask if they have any surgeries at all. That includes wisdom teeth. The wisdom teeth are going to be affecting the position of that sphenoid bone, or the bone the brain sits on, that anchoring point of the dura. So I also want to know about dental work that they've had. I want to know just generally how their other organ systems are. So I'll say, even though this is on my intake form, so they should be putting on there, I want to say to them, okay, well, how's the heart? How are the lungs? How's everything else going on? Then finally, now this is the new one that I ask, is, has anyone had COVID? Because I want to know if that could be potentially the problem, is the adhesions of the pericardial ligaments. If you don't know what I'm talking about, go back to my episode 7, where I talk about treating patients post-COVID and long haulers. But from that episode, you'll hear that there can be restrictions all over the body, and it could just be because of the pericardial ligament restrictions. So I want to know, regardless of what they're coming in for, if they've had COVID. Now, if you've gone through all with the patients and you're still not 100% sure where we could be going with this, or you feel like there's something more, then the trick I do to get more out of them is I start to educate them a little bit on what I'm thinking is the problem with their system. And then it's amazing how that jogs up some memories. So here's an example from just last week. I had a guy coming in who's having shoulder pain while he's playing tennis. He's been seeing his other physical therapist. It's been getting a little bit better. They're mostly just doing strengthening stuff, but it's not quite there. And he has no idea what the cause is. I'm going through things, trying to get him to jog his memory. Does no idea what the cause could be. But any overhead motions, he's having issues. And he said anything overhead and it hurts right on the top. So the first thing I started to think is it's shoulder impingement. I thought that the cause might be neural tension. So I'm like, okay, let me just educate him a little bit of where my brain is going. I think it's really important for patients to understand the education purpose of this, that they need to know what's going on with their body so that they could avoid doing those things in the future. So I kind of started to talk to him about how this idea of the hyper versus hypomobility. So that hypermobility could be was the shoulder moving around too much because there was not enough motion of the nerves, that the nerves were really tight and thus causing abnormal or aberrant motions of the shoulder to try to compensate for that tightness and not wanting to stretch the nerves. Because remember, the nerves, that nervous system and the cardiovascular system reign supreme in terms of the hierarchy of the organ systems. So the nerves don't want to be injured and they will cause changes through the musculoskeletal system to avoid that. So I started talking to him about this idea of this might be a neural tension component. The nerves are going down all the way into your hand. And if they don't have good mobility, it could cause the shoulder go in weird positions. And so when you're doing the overhead serve in tennis or having to do any overhead presses, that's kind of causing your pain. And then all of a sudden he's like, hey, that reminds me. I was actually having issues with the mouse. He was working from home and he was having to do a lot of clicking and move around the mouse. He goes, it was kind of bothering me. So I got this other mouse where I can stay in one position and it's a vertical alignment. And you know what? My shoulder got better from that. And I'm like, oh, ding, 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 ding. Yes, I think that's a neural tension component, that your arm wasn't as stretched as much. He wasn't in this wrist extension. He was able to be in a more neutral alignment that meant less tension on the nerves. So then I started to show him how that connection was. So sometimes if you just let your patients in on a little bit of where your brain's going as to what the problem is, then it's amazing how it can jog their memory of oh, hey, I don't know if this relates, but I've got this information. And guess what? It usually relates and it kind of helps you fill in the pieces. So that's a fun little trick, a little Jedi mind trick, shall we say, to get them more information, is just to start to educate them a little bit. So let's talk about building rapport. After that initial evaluation where you kind of set your plan of care, a lot of people view that subjective intake is now just a minimal component because now you have your idea of where you're going to go with your patient and why do you need to know more information about their life. No, you need to keep that rapport going. That subjective intake, when the patient comes in for those follow-up appointments, you want to get as much information as you can from them. Now, that doesn't mean that you need to be sitting there for the entire time just while, wasting away at your patient time talking about things. No, you can kind of get a quick, hey, how you feeling from last time? What's going on? What's changes? How are those exercises? Kind of get the lowdown of what's going on. But then while you're treating them, while your hands are on them, be building that rapport, finding out more about what's going on with their body, more what's happening in life with them, because it can start to bring a lot of the pieces of the puzzle together. So I have two examples for this. One was my patient. She had low back pain and she'd been doing really well. And then all of a sudden she had a flare up of her low back pain. And when I was talking to her first, I was like, okay, well, did anything change? Is anything different? Did you sleep weird? Did you lift something? I'm going through all the questions to try to jog her memory as to what could all of a sudden cause this increase of her low back pain, which seemed to have no cause at all. And then as I'm treating her, I'm talking to her about, hey, how are your kids? She goes, oh, it was great. Yesterday we actually did a field trip. I'm like, oh, a field trip. What was it? She goes, oh, we had to do this obstacle course, this ropes obstacle course up and elevated. And she goes, and I'm terrified of heights. And I was so scared to do it. But my daughter was telling me, no, come on, mom. The rest of the moms did it. You have to do it too. She's like, oh my goodness, I couldn't even stand it. And I'm like, okay, well, when did your back pain start? This morning. And you did an obstacle course where you were elevated wearing a harness scared out of your mind, and you don't think that was related to the flare-up of your back pain? Maybe, yeah. So it's about kind of still talking to her about her day and finding out what's happening in her life and having that personal relationship with her, that she was able just to kind of give me the piece of the puzzle that I needed to know. Because in my head, I'm like, what could have gone wrong? She's been doing so great. I was going to discharge her soon. Like, what could be this component? And then getting her to realize too, especially with your patients that have chronic pain, getting them to start to connect the dots rather than feeling they have complete, lack of control of what's going on, that they're at the mercy of their pain. It's like starting to connect the dots for them is really important. Like, oh, did you notice that when you did this activity, this was the outcome and your pain increased? Let's talk about the biomechanics behind everything. Let's talk about what was it that's happened to your body that brought to you where you are now, where that activity might not have helped you. It could have hurt you in the process. So it helps them to be able to figure out what they need to avoid. So it's really important with your chronic pain patients that you're trying to get them to understand this cause and effect. And the only way you can do that is finding out what they're doing in life and what their activities are, because they're probably not connecting the dots. Because my patient did not connect the dots whatsoever that yesterday when she was doing something that terrified her and it was really physical, that could have any connection to the increase in her back pain. So finding that out. Another patient I want to talk about is a patient who, this is only the third time I had seen her, and I had seen her specifically for digestive issues. She was having a lot of constipation. She had had 13 surgeries in her abdomen. 13. So there's a lot of scar tissue I was dealing with. And in our third session, she said, this is a little embarrassing, but I have to be honest. I had some fecal incontinence. I said, okay, so that means that she lost her bowels. And I was like, okay, well, when did this happen? She goes, I was at my grandson's soccer game. And she's like, I had no idea that I had lost my bowels until I stood up and I felt it running down my leg. And this is very concerning to me because I'm like, you didn't notice it. You didn't even feel it until it went running down her leg. So in my mind, so any, healthcare practitioner, this is a red flag because it's like you didn't have sensation around there. This could be a sign of a spinal cord injury. Something's not right. And this is outside my practice access. Is that outside what I'm able to do? And she goes, yeah, and it happened again yesterday. She goes, I was down working on something. I think she was sewing something for her granddaughter and had no idea until she stood up and felt it running down her legs. And I said, well, what did your doctors have to say about this? Because I knew she had met that week. Like the day before she had seen me, the 2 days before, she had met with her GI doc and her urogynecologist surgeon. And I said, well, what did the doctor say? And I was like, she goes, I was too embarrassed to tell them. I'm like, what? She's like, yeah, I was too embarrassed to tell them. She goes, my urogynecologist, I felt like this wasn't appropriate to talk to her about. And then my other doctor, my GI doc, he was just really busy that day. And he just seemed like he was rushed. So I didn't want to bring that up. And I'm like, that's terrifying that these doctors that she has known for years, and I mean years, she didn't feel comfortable talking to them about fecal incontinence. But me, on our third session, she felt comfortable talking to me about it. I'm very happy she did. I said, we need to call your doctors. Do I have your permission to call your doctors and tell them what you just told me? Because this could be something more serious, and that's outside what I can do for you. And I don't feel comfortable treating you until this has been ruled out as something more serious. And she said, you would do that? Okay, yeah, sure, I'm fine with that. So she was fine with me going and talking to the doctors, but she didn't feel comfortable. So it's building that rapport. You want your patients to feel comfortable talking to you. And patients, if you're listening to this still, you need to feel comfortable with who your healthcare practitioner is. So if you don't feel comfortable talking to them, you shouldn't be with them. I don't care if they are the greatest doctor in the world that, everybody goes and sees this person. If you can't be honest and have a true conversation with them about what's going on in your life and what's going on with your pain, then you shouldn't be with them because they're not going to be able to help you. You want to be with that person that you are comfortable with. So luckily, it turned out that it wasn't anything serious. There was an issue with her medication that we needed to get changed, and then the fecal incontinence stopped, that she had full sensation. It was just something that was a little off of how she had been sitting, but I was glad that we ruled it out, and I'm glad that she told me rather than hiding this, because if it was something more serious, I would be really upset to know that, this wasn't caught sooner where she could be helped. So the rapport doesn't just end with that initial evaluation. You talking to your patients, and patients, you talking to your therapist that's not over just after that initial eval. It needs to continue from there because that's what's going to help you get to the root cause of your pain. In the initial stage, it's to help your therapist figure out where they need to go and put all the pieces of the puzzle together because everyone is unique. Like I say, you give me 100 people in the room with the same medical diagnosis, and I'll give you 100 different reasons why they have that diagnosis. And it's the why that's the important part, not the what is the diagnosis. So you need to, that first initial eval is to try to figure out the why. Why do you have this pain? Where do we go from here? And then later on, it's about learning the patterns of what causes your pain, what makes you feel good, and understanding the biomechanics of those, because you haven't been able to maybe connect the dots before. So it's through that education of your therapist that they should be helping you to figure out why X, Y, Z caused pain increase, and you can understand that better. So it's this constant communication back and forth. So patients, you need to feel comfortable talking to your practitioner, and practitioners, you need to feel comfortable talking to your patients and really trying to learn to get as much information as you can out of them, because that's going to help you get to the root cause of the pain. So everybody needs to get used to learning their history and really learning the specifics of it and understanding where this all came from, giving more information than not. And therapists, you need to learn how to pull this information out of them and help start to connect the dots if they don't understand it themselves. Because if we want to get to that root cause, we need to understand what the cause is first. Thank you for tuning in to this episode of the Body Fusion Therapy Podcast. Please share it with your friends and family, as well as leave a review if you liked what you heard today. We're looking forward to continuing this journey of looking at the body. Tune in next time.